Since we've solved all the issues having to do with high deductible health plans and enhancing preventive services, let's add some more work to our desk here. We're going to now look at enhancing access to essential medications. And there's a lot kind of even embedded in the title here, because what are after all essential medications? Why do we need to enhance access to them if they're supposedly essential? What's in the way, and how do we kind of go about knocking down those barriers? And I know that everyone's been witness to such issues as what does it cost to get insulin every month? And that's a huge political issue. I think we're also going to hear about things like out-of-pocket maxes and out-of-pocket smoothing. We want to also delve into some related issues on equity and drug shortages, maybe a little bit on cybersecurity, things like that may sort of mediate how we do gain access to what are defined or will be defined as essential medications. So with that, I'm going to ask each of our panelists to introduce themselves. Stacy Ducicino, would you get us started, please?
Sure. Hi, thanks for having me today. I'm Stacy Tusetzina. I'm a professor of health policy at Vanderbilt University Medical Center, and I spend an awful lot of time thinking about how people are able to access medications and how insurance benefit designs are set up to make that possible or less possible. So I guess
your connection to the issue, and then we'll have Inma introduce herself.
Yeah, my connection to the issue is really as both thinking about it as a person who studies the system, the health insurance design, both Medicare and commercial plans in particular, and thinking about that interaction between what people pay at the pharmacy counter and what that means for their ability to actually take their medications as recommended.
And by the way, Stacy, you've spent a little time on Capitol Hill lately?
That's right. I am on MedPAC right now, so and I spend quite a lot of time reading about and thinking about Medicare payment in particular, and also had a lot of opportunities to interact with different staffers and committees around the Inflation Reduction Act.
Great, thank you very much. Good to know. Inma, can you sort of self-introduce and remind us what your connection to this issue is?
Hi, my name is Inma Hernandez. I'm a professor at the University of California in San Diego. I'm a pharmacist by training, although I don't practice any longer. So I guess my connection is partially from my past clinical life, as well as the research I do now around pharmaceuticals and access.
And tell us, Inma, you've also had some kind of engagement on the political side of these issues. Can you share a little bit with that?
We've been working recently on a couple of topics that I'm going to share today about, which are generic reimbursement and shortages, where I've had the opportunity to interact with some of the folks on the Hill working in these issues as well.
Thank you very much, Inma. So, Stacy, back to you. I know that one of the things you're going to get into is Medicare versus Medicaid and some related issues, but give us your best 8 or 9 minutes.
All right. So I'm going to start by breaking up my comments into two broad areas when thinking about access to essential medications. And one will be talking more about access to more commonly used high-value drugs, like the ones you mentioned up front. So insulin, inhalers, blood thinners, things that we think about that are used by a lot of people and need to be used chronically. And then I want to talk a little bit about some of these other medications that are big budget items. So gene and cell therapies, CRISPR-based technologies, and also drugs that would be used by a lot of people. So GLP-1s, which have come up multiple times already, the obesity medication. So I'm going to segment my comments talking about those two a little bit differently and where I think things stand for access. So the first is, I think about access as being mediated or, potentially prevented by your health insurance. So the type of health insurance that you have really is how we think about your ability to access your treatments. With Medicaid, I tend to focus less, and I'll focus less on Medicaid in my comments today, except in the gene and cell therapy space, primarily because once the FDA has approved products, Medicaid generally covers those products at low cost sharing for patients. So when we think about access, Medicaid enrolled individuals tend to have fairly good access at low costs. There are always exceptions, but I'll spend more time talking about commercially insured people and Medicare insured people and some of the challenges of accessing medications. One is, if you've been on this meeting the whole time, you've heard a lot about deductibles. That is a key problem for access to medications. So deductibles, you're paying the full price, the list price of the drug. There's also coinsurance where you're paying a percentage of the list price. And we know for many common brand name drugs that the list price is often much higher than the negotiated price that that health plan is paying. That could mean that you're paying a lot of money every time you go to the pharmacy counter. It also could mean that you don't know how much money you're going to have to pay from one fill to the next. So your price might jump around. And we see this a lot in Medicare, where even for preferred brand name drugs, you might start out the year paying a copay, a flat fee, and then it jumps up to a coinsurance as you spend over the course of time. So we know that unpredictability can really make it hard for people to know like what to expect at the pharmacy and to budget accordingly. So these are the things that make it, I think, just generally difficult for people to be able to access and use medications as their doctor has recommended. Obviously, we have some changes that have gone into place. So I'll mention a couple of bright spots here on this type of medication. Some high value treatments are now much more accessible, especially for Medicare beneficiaries. So $35 insulin copay caps. Other states have been passing those laws for commercially insured people in some health plans. Again, it doesn't resolve the issue for many people on commercial insurance, but many states are taking actions there as well. We also have no cost sharing for vaccines offered under Part D. That's part of the Inflation Reduction Act for Medicare beneficiaries, so that improves access to high value treatments. And the Inflation Reduction Act is also going to stabilize the payment from 1 month to the next. So for Medicare beneficiaries starting next year, there's going to be a simpler benefit design where you can predict your costs from one fill to the next. And there's going to be a $2,000 out-of-pocket maximum. So there are some bright spots when it comes to access to drugs, at least for Medicare beneficiaries. And I think we've seen employers being more creative, thinking about offering some treatments pre-deductible, for example, as we heard in the first session. So there are some opportunities for improvement. I'm going to shift now to talk about a couple of the big picture items, the high cost, high budget impact drugs that we're all going to have to figure out. So, and this relates back to the affordability overall. So when we think about things like CRISPR technologies, gene and cell therapies, we're talking about drugs that are really innovative, very high value for patients, and look to have somewhat durable response, although it's, we are still learning about these therapies. They're millions of dollars per patient treated. So this is a real budget impact. And we also know that this disproportionately affects payers like Medicaid, where they have to deal with a fixed budget. So that puts a lot of pressure on the system to try to figure out a way to pay for therapies. We also know with things like the GLP-1s, the obesity medications, their prices aren't nearly as high per patient, but they're still high. And we have so many people who could potentially use them that they put a lot of budget pressure across the whole system. And though they're highly effective, they're not cures. So they need to be used chronically to maintain benefits. So this is another place where our system is really trying to wrestle with exactly how to manage treatments that have a lot of value, that show a lot of clinical benefit, but that have a massive budget impact. And one of the things that I think is worth kind of wrestling with a little bit is that if, we open up access to all such therapies, that puts a ton of pressure on premiums, which then could potentially make health insurance itself unaffordable for many people. So we have to, when we think about what we're paying for, we always need to remember that, we're not really asking the health insurance company to pay for this ultimately. It gets passed along to employers, to workers, to people who are paying for health insurance. And we need to make sure that those dollars are being used wisely because they're all of our shared dollars, including taxpayer dollars when we think about Medicaid and Medicare. So I will say from a solution standpoint or things that are working through the system there, to be determined on the GLP-1s. I know there's a lot of interest here. There's a lot of question about who's going to pay, how they're going to be covered. But for gene and cell therapy, CMMI has recently announced a demonstration project to do negotiated outcomes-based agreements across Medicaid programs to try to consolidate negotiations better. That's a voluntary model. There's a lot of details to be worked out, but at least there are some concerted efforts to really recognize these high-value treatments and drugs that we want to have access to. They could potentially really improve health equity, though there's a long path ahead, I think, given the amount of money and the number of people that need treatment.
Stacy, and before we go to Inma, a couple of questions. It's very helpful how you sort of divided the universe into the insulins, inhalers, and blood thinners versus the gene and cell therapies and the CRISPRs and so forth. You also kind of talked about the GLP-1s and whatnot. There's been an interesting experience with the Alzheimer's therapies, these monoclonal antibodies that are supposed to kind of go after and eat up all the amyloid plaques and so forth. And I think at least one was approved by Medicare this past year, and there's another one in the pipeline. Do you see sort of a welling up of a critical mass of not most expensive, but medium expensive on a unit basis, but massive population base that could really break the system when it comes to paying for these things? Is that kind of the issue, one of the issues that we're facing?
I mean, it's a really good question because we do see these things coming along, and I think it is pushing us to think harder about how do we really value treatments and have, value-based insurance design principles apply. So one of the challenges is you can debate about the merits of specific drugs. So the Alzheimer's drugs in particular have much modest clinical benefits available for people at a high price. Weight loss drugs have very substantial benefits that are accruing in clinical trials, but they're also high priced and would apply to a much larger population potentially. However, these are really important questions for thinking about, like, what do we all think is worth paying for? What is helping advance people's health? What is producing longer term savings or downstream reducing medical spending? These are really complicated questions, but I think people really, when you think about if we had a cure for Alzheimer's, that would be incredibly expensive, very large number of people to take it. But gosh, wouldn't we be all better off, right? So we have to figure out how we would be able to fit that into a budget. I think sickle cell is one where I'm thinking about it a little bit in the same way. This looks like a transformative therapy, but the question of asking states, to voluntarily sign up for a model and try to figure out how to make the math work, even if you had substantial discounts for those drugs, it's hard to imagine states being able to fit that into budgets. And so I think we'd have to really be creative about how exactly do we pay for it and where do we invest in a more of a, single payer type of strategy or negotiation, thinking a little bit like how we handled COVID vaccines and treatments, as when we have such innovative treatments that are real breakthroughs for people, should we think about those not as this fragmented set of payers, but in a more coordinated way?
I see. So this sort of new wave of blockbusters, whether they be the Alzheimer's drugs or the GLP-1s or other, it's not just they're very expensive on a unit basis, of course, but now you're saying that we need to maybe take a broader, more integrated look about how do we manage a whole set of new medications like this. And that's a further question. I think you suggested ways of sort of coordinating efforts and so forth and looking at it big picture. So, well, gosh, thank you very much. Inma, I know that you want to hit on a couple of these issues as well as introduce things like equity, drug shortages, maybe some cybersecurity. You've got some other issues to raise as well. Inma?
Thank you again, Cliff, for the invitation to participate today. So my remarks are going to be centered around barriers to medication access that are not necessarily related to prices and insurance coverage. So this is meant to be complementary of the points that Stacy brought. Some of the issues I'm going to be talking about have happened for years, like drug shortages, and remain unresolved, but others are new emerging issues like cybersecurity.
Right.
The first threat I would like to discuss is the over-reimbursement of generic drugs in some cases by pharmacy benefit managers. So last year, my team and I looked at reimbursement rates for generics in Part D, and we found 16 generic drugs that were reimbursed at least by one Part D sponsor at a markup of 1,000% or higher. So for instance, aripiprazole, which is an antipsychotic drug, has an acquisition cost of 17 cents per tablet, 17, meaning that pharmacies pay around 17 cents to buy one pill of aripiprazole. However, some PBMs like Rite Aid, and when I mean Rite Aid, I don't mean the pharmacy chain, but the PBM, was paying pharmacies as much as $11.7 per tablet, which we're talking about here of a 7,000% markup. Over reimbursement is also pretty common for a generic cancer drug called imatinib. Actually, both Stacy and I have done research on this drug. A tablet of imatinib, for instance, cost around $4 in 2021. However, CVS Health, the PBM, was paying pharmacies over $240 for a tablet. So in a 30-day prescription, we're talking about a markup of over $6,000, again, per 30-day prescription. These practices are concerning because these point-of-sale reimbursement rates are the basis for patient cost-sharing. In other words, if we have a patient that pays 20% cost-sharing, they would be paying 20% of this inflated amount. Some have attributed these high reimbursement rates to potential anti-competitive behavior. I'm not going to go into it because that's very hard to test as we don't have data on post-sale clawbacks. However, I think it's clear that beyond these extreme cases, there's been an extensive body of literature that has described that many times patients pay more out of pocket for generics when using their insurance benefit than if they were to buy generics in cash. And this is the basis for the popularity of the Mark Cuban's cost plus model.
And before you go on, could you just go back over that? Why are patients having to pay so much more for generics in some situations? What's that about?
So I'm not sure if you're talking about, so I like to distinguish between maybe the extreme cases, like what I like to call over reimbursement. And I think there's been some concerns whether that may be PBMs that are integrated with pharmacy chains trying to push profits to the pharmacy side of their conglomerate. But in other cases, I think maybe without concerns for anti-competitive behavior, we see patients that often pay, as Stacy also said, higher co-payments for generic drugs when using their insurance benefit than when paying in cash. And that's just a function of how the pharmacy benefits are set up. So it's certainly an area that, in my opinion, is prime for policy reform.
The design of the pharmacy benefit itself. Yeah. Got it. Thank you.
I was going to say now that I think it's a nice leeway that there's been some groups that, based on these trends, have suggested that maybe we should just remove generic drugs from insurance benefits, as one can argue that generics are inexpensive and also relatively predictable expenses. I think that this solution is too drastic and too problematic for several reasons. First, we do have generics, like complex generics, that are expensive. Second, if we carve out generics from insurance programs, then less patients will uptake insurance for drugs, meaning if we think about removing generics from Part D, then seniors who only take generics will be less likely to enroll in Part D, right? And eventually, when they are actually prescribed brands or specialty products, they will have less access to them. So just to wrap up this section, I think we've spent a lot of energy, a lot of work on thinking about reform of the reimbursement of brand name drugs. This culminated with the passage of the Inflation Reduction Act, which I think brought very important measures in terms of reform. I think it's now also a good time to think about reforming the generic drug reimbursement. Because as I said, and as we're discussing, in many cases, the existing practices of PBMs may lead to patients paying more out of pocket when using insurance than how much the drugs actually cost. The second theme that I would like to discuss around access to essential medicines relates to vulnerabilities, of the drug supply chain. We are currently experiencing a record high of drug shortages with over 300 drugs on shortages. This is not anything new. Shortages have been prevalent. We are just at a record high in terms of number. Shortages disproportionately affect generic products with low prices. And again, this is an example of an access barrier to medications that even if prices are low, patients cannot access the drugs because they cannot find them. The way how we pay for generics is also considered one of the drivers of shortages. So basically, pharmacies and providers get paid the same amount when they dispense or administer a generic product, regardless of which manufacturer is selected, meaning regardless of whether they dispense Teva or Mylan or another manufacturer. So as a result, generics solely compete on price. This generates a race to the bottom in terms of prices that in some cases can threaten the sustainability of the market. And this is particularly the case for injectables, generic injectables, because they are more costly to manufacture than oral drugs. That is because we need specialized manufacturing processes for drugs that are going to be injected in the body. I think that this pricing pressure interacts with the limited ability of manufacturers to raise prices when costs of production increase. This is related to the inflation rebates that we have in Medicaid and 340B, but also to price protection clauses in contracts with wholesalers and group purchasing organizations, which really dominate the market in terms of like a few of them having control of over 90% of the market. So as a result of this price pressure, many times manufacturers lack incentives to invest in resilient supply chains. And in some cases, profitability may be so limited that manufacturers ultimately may decide to exit the market.
Now, is that primarily for generic drugs where manufacturers don't want to invest in supply chains?
Yes, this is primarily for generic drugs, especially those ones that have low prices or that have high costs of production compared to the costs.
Like the injectables, got it.
Right. So there's been a few hearings, if you heard, in Congress in the past few months around drug shortages. One of them actually discussed value-based reimbursement, and they made a reference to Vivid and the Michigan team in terms of how value-based reimbursement could be used as a potential solution to drug shortages. So we're thinking here of maybe providers getting paid a higher amount when they select generics that come from more resilient supply chains. So as I said, right now, the status quo is that we pay the same for any generic version. The idea would be to pay more for generics from companies that commit to supply continuity standards as a way to prevent shortages. Also related to the vulnerability of the drug supply chain, I would like to discuss cybersecurity. You may have heard that a few weeks ago, a claim processor suffered a cyber attack, and this triggered a nationwide disruption in the ability of pharmacies to process claims, also in the ability of medical practices and health systems to process claims. If we think about drugs, it's my understanding that in the majority of the cases, pharmacies try to dispense the drugs to minimize access issues. And then they were hoping to submit the claims as soon as the system is restored, which I understand is going to be this week. So I think this is one case where luckily pharmacies were able to buffer the effect of the attack in terms of preventing an impact on patient care. And the attack has been limited to a few weeks, also because it sounds like a ransom was paid to the hacker. But otherwise, they could have triggered a major cash flow for pharmacies and health systems nationwide. So maybe although this time major patient harm was averted, that may not be the case next time. Other countries, for instance, have seen cyber attacks of wholesalers that have paralyzed drug distribution for months. This is a huge risk because we have here a market where 3 wholesalers dominate the majority of the market. So if one of them was to have a severe disruption, it could be truly detrimental to patient access. I think that both Congress and CMS are aware of the vulnerabilities associated with cybersecurity, and they are working on it. Maybe not particularly centered around drug supply chain, but centered around health system. But in any case, I think this is a new emerging threat to drug access that is unrelated to prices, but that we will have to keep track of in the future. And I'm going to conclude by talking about another threat to patient access to medications that is not related to price either.
We
And
already
that-
have so many. You're going to give us another threat?
So I can leave it there too. I don't
No,
know,
it's
maybe
so
this-
much. It's
Oh,
just,
okay.
you're so correct about this is a multi-factor problem.
We, Stacy and I tried to organize this talk to have her covering the price-related threats, right? And me covering maybe some of those that we may not think about, but that may be important issues. So I will just finish by talking about pharmacy deserts, which are proliferating and are becoming increasingly common and are really important for equity because we know that the recent trend of pharmacy closures have affected independent pharmacies disproportionately, and independent pharmacies are more likely to serve rural and underserved communities. I think we need to think about the relevance of having pharmacy access as we talk about drug reimbursement and reform. So increasingly, the drug market is going to be divided into generic drugs and specialty products, right? And small molecule brand name drugs will be represented a smaller share of spending. So if we have patients getting generic drugs from Mark Cuban and specialty drugs from mail order pharmacies affiliated with PBMs, do we really just expect pharmacies to remain open when we need them to get COVID vaccines? I'll leave you with that. So in summary, I talk about some access barriers to medications like high out-of-pocket costs for generic drugs, cyber attacks, drug shortages, and limited spatial accessibility to pharmacies. This is not meant to be a comprehensive list of access barriers. I know Cliff, you already said I had too many, but just a sample of some new and some prevalent issues that threaten patient access to important medications beyond prices, and some issues that, in my opinion, are also prime for policy reform.
Well, thank you so much, Inma. You know, it's just that, at least going into this, I thought I was aware of all the access barriers, but you've really fleshed that out and added some more. This cybersecurity thing which hit, it hit Change Healthcare, which is a subsidiary of United Health Group, far-reaching issues there, and people are concerned that they had too much of the market. And if you can knock out a Change Healthcare, you knock out much of the system across the country. So maybe they had too much power, too much of the market. Stacy, back to you. Just want to ask, you know, I recall over the many years that a basic tenet of VBID is that patients don't really care about kind of the posted price of a drug. They care about how much it's going to cost them out of pocket. So when we talk about price transparency, Stacy, what would really make a difference? I'm just wondering, as one of our questioners pointed out, Jerry Kluel pointed out very nicely, even if you have these things posted, that might not solve it. How do we get price transparency that is meaningful to patients?
Yeah, that's a great question. And I guess I'll tip my hand that I am not that fond of price transparency for helping patients to shop around, because often they're just bound by their health insurance. So unless you're filling a generic and you can do things like search for, you know, a discount price, which pharmacy has the best price, usually you don't have all the information that you need. So for example, if I go to the doctor, they'll often ask me, oh, are you still going to this pharmacy over here? And they put that in. Maybe that's not a preferred pharmacy for my plan, but even I, as a drug policy expert, might not know that specifically to be able to say, no, route it to this other place. That's the best deal. And so I think that we often try to give consumers tools to find out more information about prices, but it asks them to actually know a lot more than the average person would know. So I feel like we need to set up policies that make it easier for people to know, like, what is the preferred thing to be doing. So it's one reason I like VBID and things like reference pricing for health insurance benefits, where you say, here's the plan's preferred treatment for you. It's no cost or it's very low cost, and everything else is relatively higher cost. So I think if, to whatever extent we can set up policies that make it easier for people to just go on with their lives, get the medications that they need, and be kind of nudged to the right choice when there are multiple choices to be made. I guess that's my preferred way of managing the system, just because the information needs are so high to be able to get this right.
Point well taken. Inma, would you agree with that with regard to across various population groups as well, the ability to kind of sort of navigate the system, even know what questions to ask, to even get at the real meaning of price transparency? Do you have a take on that?
I think Stacey's remarks were right on point. It's very content dependent, and it really depends on how the patients access drugs. So
Point well
sometimes
taken.
when we talk about drug access, we put everything together, right? The specialty brand name generics. But as they were saying, the point of transparency is really different, because there's major differences in the way how we pay for drugs. And that's why also I made the point that we work a lot on brand name reimbursement, but that doesn't mean that we don't need reform in some of the other aspects.
Absolutely. I need to pose the question that Patricia Anstedt posed to us. It's kind of an obvious question. It's a perennial insofar as policy, but she says, look, many drugs cost less in other countries. Why can't the United States get prices down? What would that take? And Stacey, maybe to you first, did the IRA sort of start getting at that with the top 10 list? I mean, are we anywhere near that? What's the big differential, by the way? Why Western Europe, other wealthy countries pay far less for drugs? What's the big difference here?
So one of the big differences is the fragmentation of the US healthcare system that results in not having a single large purchaser, because overall the US purchases far more drugs than any other country. But when you break it up into each state Medicaid program, and then the federal government covers Medicare, and then we have commercial insurance companies, and so you end up with a fragmented payer setup where no one has quite as much leverage in negotiations. And there's also, I think, just been a lack of political will to do something. These other countries will say, well, here's the line in the sand. This is how much we're willing to pay for this drug, or it's not on the national formulary, period. And companies have to decide, are they going to walk away from selling their drug in those other countries if they can't meet that price? And we are a country that loves our choices. Like, we want to have access to everything. So we don't want to make those harder decisions about restricting access or saying no, which then means that we have kind of not great access to a lot of things that are really high value treatments. So our lack of willingness to make decisions at this higher level and negotiate more is putting us in a bind. And, to your question about the IRA, yes, it's starting to go down that path for negotiations. It's certainly, we're going to learn a lot this year. We'll know what the negotiated prices are for the first 10 drugs in September. And we know there's negotiations underway. So we'll see how effective it is. But you're probably also, at the audience is probably well aware that the companies whose drugs have been selected are all suing to stop the negotiations. And I think depending on the outcome of the election, it could potentially put those negotiations at further risk.
Aha. Although worrisome. Inma, did you want to add anything about some of the cross-national differences in prices and why
No,
we're at a
I
disadvantage?
I think that was on point. I grew up in Europe, and it's exactly like what Stacey said. Like, if you don't agree to a price, you will be out of national formulary in a country where 95% of the drugs are reimbursed by the national health system. So pharma has to make that decision, right? Here, the issue that plans in many cases cannot not cover drugs, or for instance, Medicare protected drug classes, is preventing us from being able to negotiate further. Research from my team and from other teams, we've demonstrated many times that there's lower discounts for drugs that are in Medicare Part D because protected drug classes, because pharma obviously knows that all of them need to be covered. So while those tend to be not very popular policy solutions, one needs to integrate them in the context that it would increased negotiating power that we could need to get further discounts and decrease prices.
So until we have, and no one's looking forward anytime soon to a single payer system, we don't expect that. We don't really have in the United States the big enough leverage to really sort of negotiate with greater power. And without that, it's just very difficult to have any true leverage in that, notwithstanding the top 10 that come out of the IRA, I guess. A question came in from Jeff Levenshirtz. I think that this refers, Inma, to something you said about the overcompensation by PBMs. And what Jeff is saying has to do with litigation. And he points out that the lawsuit against J&J alleging that the company did not exercise appropriate fiduciary responsibility over its employee health plan could increase pushback against the overcompensation inlet to which you referred. And Jeff is wondering whether you could comment on whether that kind of litigation could make any difference. And I know PBMs have already come up earlier today. They're a very powerful sort of player in this space. Inma, can you respond to that?
I think it's a very interesting event. I think it's going to be interesting to see how it's going to pan out because they sued the employer, right? Not the PBM. So I wonder whether that's going to lead to maybe employers trying to do a little bit better homework in terms of contracting with PBMs. But that not only happens in commercial insurance, that is happening in Part D, as the results that I described from my study are in Part D, and that's happening under CMS purview. So maybe it's not just employers.
Well, PBMs are a favorite target of many. Something else that came up actually before the session has to do, and I think maybe Inma briefly mentioned 340B, not sure. So 340B program was designed to do something with wonderful intentions. The idea behind it was wonderful. And we know that for various reasons, including hospitals that didn't originally qualify for 340B are buying clinics and so forth that do. So then all of a sudden the big healthcare provider organization gets the benefits of 340B. Is 340B, Stacy, at this point, helping us or kind of getting in the way of better access and better pricing to drugs? Is 340B working well enough to hold on to it or not?
So I would be curious of Inma's comments here as well. I think the question of who it's helping is a good one. So a lot of medical systems, including those that are large systems that don't really treat people who are underinsured or who are Medicaid insured, for example, benefit a lot financially from 340B. And so it ends up being a massive source of revenue for hospitals and health systems. And you've seen a lot of expansion of 340B, including through these contract pharmacy relationships. So there's a lot of money flowing through that program. I think one of the key criticisms of that program is the lack of accountability. So there should be making sure that if you're serving people who need lower cost drugs, you're passing those low costs onto them. And there's just no visibility into that. And also the community benefit related requirements that you're using those dollars to actually fund programs that are helping the community and helping to offset other costs. One of the things that I always find is that there are a lot of services that large hospitals, centers that were initially intended to really benefit from this, federally qualified health centers, for example, there are a lot of services they don't get directly compensated for. So the overpayment for drugs is meant to kind of pay for many of those services. But I think it's definitely a runaway train. So maybe I'll leave it at that.
Okay. Well, Inma, do you want to catch or stop the runaway train?
I like to think about counterfactuals when we think about 340B, right? So 340B could use some reform, as Stacy was pointing out, to increase accountability of where these discounts go. But when we talk about 340B, are we talking about just getting rid of it? Because I think that's the point of it was developed with good intentions, and I don't think maybe the counterfactual is a goal without that. Is just probably thinking about how we could make sure that the discounts are used as it was originally intended.
Point well taken. So question then about the kind of high-end stuff. Stacy, you mentioned cell and gene therapy. We talked about the GLP-1s, which they're not $1 million drugs on a unit basis, but they can add up. I think they're $1,300 a month now. Thereabouts. From an equity standpoint, with these kind of cutting edge drugs and so forth, and actually the GLP-1s for obesity might even disproportionately benefit some disadvantaged populations based on patterns of obesity and so forth. Do you still see a large gap from the standpoint of equity to access for these cutting edge breakthrough drugs? Is that still going to be a problem for us? Stacy, and then Inma maybe as well.
Yeah, absolutely, no doubt that there's potential to actually worsen health equity as a result of some of these medications, despite the fact that we know that they actually could disproportionately benefit such populations. So, for example, sickle cell therapies have a potential to really help to lower health inequities because of many people with sickle cell disease are Black individuals. We also have like many people on Medicaid. So people where we're thinking about both income, race, other factors weighing in. So the ability to have really transformative therapies for people that could help, dramatically increase like their lifespans, their quality of life, productivity, et cetera, these have a lot of potential, but we know that they're also, being on Medicaid, very difficult for Medicaid programs to figure out how to fit them into a budget. And even when we think about solutions that are being proposed, like the gene and cell therapy model, for example, that's a voluntary model. There's also a potential that states may elect to participate or not based on local politics, based on the demographics in their state. For example, we've seen a reluctance of southern states expanding Medicaid for many years. Like if there's a reluctance to join the model, then that may mean that people in different geographic areas have very different access to these technologies. So, while on the one hand, it's like, yes, treatments that would disproportionately benefit subpopulations who have been historically disadvantaged and, discriminated against in many cases, that we still have payment concerns. And also, if we think about GLP-1s, those are going to, people who have the resources to pay cash mostly right now, right? So as we're figuring out like who can pay, what benefit designs are going to look like, what employers are going to offer those on employee-sponsored benefit plans, it's likely to be for better financially, able patients who can go and pay cash right now to get first access, and hopefully can expand out to other folks. But then the question is then do we put premiums in a place where the lowest income people in our, where we're employed in our communities can't afford even to pay health insurance premiums?
Point well taken. Inma, would you concur?
I don't think I quite agree on this one, because precisely the reason why they are going to exacerbate inequities is because of lack of insurance coverage. And you mentioned, Cliff, like a price tag of around $1,200 per month. That's before discounts. After discounts, we're talking more probably on the $400 to $500 range. So now I want to ask you, if we had a therapy in the price range as effective as they are for cancer, do you think it wouldn't be covered? So I worry a little bit that the reason why this is not covered is because it's for obesity and there's a stigma around the disease. Because again, like I hear the prevalence of the disease, but as a pharmacist, I think these drugs have quite an impressive therapeutic profile, a price point that after discounts, I think it starts to be reasonable when we have demonstrated risk reduction in hardcore outcomes like MACE, major cardiovascular events. So I'm just worried that the reason why they are not covered is truly because of the indication they are approved for and the stigma associated with it. And I also feel we cannot pretend to be serious about health equity and have these conversations around coverage of these drugs that clearly have a disproportionate, that are indicated for diseases that have a disproportionate burden for underrepresented minorities and underserved populations.
You make a very powerful point, I must say, Inma. And Stacy, the two points you made complement each other very, very well. All right, very quickly. I'm going to say this. I'm going to give each of you a coupon. The coupon gives you one chance to pull a policy lever that would increase access to essential medications. If I'm giving you this coupon, what's the one, if you could change one policy, pull that lever, push that button on a single policy within the next 2 to 5 years to increase access to essential meds, what would you do? Stacy, what would you do?
So this is completely pandering to this audience, but I would do more VBID. So I would really push us to think harder about the coverage and the cost sharing based on the value of the treatments that are intended to be covered. That means really focusing a lot on low value treatments and making those less accessible, less likely to be covered. Stop spending so much money there, start spending more money on the things that really benefit patients and get the outcomes that we want.
Thank you very much. Can't argue with that. I mean, VBID was in on the insulin cap thing too. They had a large role in that. So thank you for that. Stacy, Inma, what lever would you pull?
I'm between two. I'm going to say PBM reform to improve transparency because I think that would lead to some savings. And the other option I had was the GLP-1 coverage, but I don't want to use my coupon card for that after the FDA news last week because I think now those concerns that I had around indication are probably going to disappear as it's been approved for cardiovascular risk reduction. So I will
Very
explain
strong.
why I didn't use the coupon like that.
Okay, well, you're being very kind of careful and value-based in your decision-making about using up coupons. Thank you. Well, Stacy, Inman, this has been wonderful. We got a lot out of you in 45 minutes, I must say, very valuable. And we always appreciate your expertise. It was a great combination to have you both on this issue. Thank you both very, very much. Thank you.
Thanks so much.
All right.
Thank you.